Commissioner Kreidler, we invited some months ago and said yes, thankfully. And we, during the last probably 3 or 4 weeks, I think may have thrown 4 or 5 or 6 different options at him to change things around. Yeah. And he tolerated all of them. As with Mr. Peter Adler, CEO and president of Molina, he has been gracious and sort of worked with us as we also have kind of moved things around on him. But no one has been as flexible as my friend Ron Sims, who actually stepped in at the last minute, but could not make it here today just at the very last minute. And so Healthcare Authority Administrator Dorothy Teeter found out she was going to be on this stage about 4 minutes ago. So she's had a tremendous amount of time to prepare. And in this holiday season, I'm sort of reminded that this is kind of like Thanksgiving dinner with the family. We just kind of have to roll with it. You never know what's going to happen. And people have asked us before, what is it like organizing this conference? And we say it's not a conference. State of Reform is not a conference. It's really a community. And we think of it as a community. We think of it as community organizing. And I think that this panel reflects that. And I say that because like at a Thanksgiving table, we have sometimes at State of Reform and in our other, when we wear our other hats, we have sometimes been critical of Molina. We have sometimes been critical of the Healthcare Authority. We have sometimes been critical of the Insurance Commissioner. They have some level of awareness of that criticism. But I just am tremendously honored and grateful and humbled that they are with us here this afternoon, because it just shows how stand-up and just how outstanding I think all of them are as individuals and as professional leaders. So with that, Commissioner, I want to start with you. We sometimes put out an email called 5 Things We're Watching, and I want to ask you, as you look to 2015, what are the things you are watching, either in the policy world or in the marketplace, the trends, the data points, the things that you're kind of keeping your eye on?
Number 1 would really be, and number 2 and 3 and 4 would be transparency is really the big name of the game right now with these narrow, more limited networks that have come into effect. We're going to continue to monitor the rule that we just adopted. We were the only state in the nation to adopt a rule that early, though I see that California just adopted under an emergency rule basis on December 5th for 2015, which is interesting how they're going to make it work with plans already approved. They're going to also have to then also have these network rule standards out there. What it really identified was the problems that they were experiencing of having too many people in plans, and they were having serious problems of knowing what they had, who they could go see, what facilities were available, and we're going to continue to be monitoring that going into 2015. We're also very concerned about the issues around drug formularies. We want to make sure that that is something that is much easier and much more available to people, so that's not a challenge for them to, if they're on a particular medication, surprises sometimes aren't very appreciated, and that's something where we're going to continue to focus on that issue. So it's making it easier for the consumer to be able to have the kind of experience of making the kind of selection of the plan, knowing the providers, the facilities, the drug formulary that's part of that particular plan, and making it easy to be able to access that. That's going to be the biggest challenge, I think, going forward is it's going to be consumers. I give the governor a lot of credit. One of the issues that is a part of transparency is certainly going to be an all-payer database, having that information available. People want to know the differences in costs because if there are copays and deductibles, let's take a look and see what plans. So if you want a particular facility, a particular doctor, if you want to see what procedures are cost from one facility to another, and their quality ratings that go along with it, and the kind of drugs, all of that being part of the picture.
Yeah. As I've mentioned, and as many of you know, we've put together this survey of our community, the 18,000 people on our healthcare, our Washington State list, and I want to just go through a few of the slides and get your responses to them. Let's put the PowerPoint up, and this is on your your USB drive, the complete set of slides, but I want to just speak to it here a little bit. We got about 400 people to participate, which was outstanding. And we put that based on our assumptions of the size of the healthcare executive community in Washington State at about 4.5 or 4.8% margin of error. This is a snapshot. You can take it for what it's worth, but I thought there were some interesting things. First, generally speaking, how do you feel about the future of healthcare in 2015? 60% of our respondents were positive. Dorothy at the Healthcare Authority, you got a lot of big stuff on your plate for 2015. That the healthcare community is generally, well, 0% down there. It should be 28. By the way, there are a few quirks. First time we've done this, so minus the, forget it, pardon our trespasses, so to speak. But Dorothy, 60% is a strikingly positive number about the future of healthcare in Washington. You got a big load on your plate. What do you take away from that?
It's wonderful to see that because I feel that in the air in this room today. I feel it as I go across the state. Over the last couple of years, as we were developing the innovation plan for the state and building on work that had, of course, come before I was at the Healthcare Authority, there was a sense that we were all ready. We knew sort of what the next steps were and what we could possibly do, and we needed to collectively join together and lead into that future. And I've really been struck by the optimism and the sense of if we work together, we actually can do this work. So I'm not surprised to see those numbers. It's great to see them for real in a survey, but
well, again, take it for what it's worth.
It matches what my travels have told me when I've been working both within the state with staff across the agencies, especially the health agencies that I work with, but also out in the field. There's just a tremendous amount of spirit of moving forward together.
How does that compare with other times in your career? At other times you've been within a silo or a part of the sector. You've had some federal experience, but now you're sort of in this place where you not only are at the state, but you interact with all the silos and the federal government. How is now a little more positive, collaborative than previously?
I have a very distinct memory of being here, I want to say probably 10 years ago. And there was a panel similar to this at the end of the day, and folks similar to us all sitting up. And somebody asked how people felt about the system of the folks on the stage, and it was a very neutral response. It's complicated, it's hard, there's so many conflicting forces, it's hard to make progress. And so I think, the change from that to now is very different, and I think it's partly because we know more, we have more tools and technology to work together. There's more of a building out into the community that's going on. And I would say, having spent a couple years on the East Coast in CMS and the Innovation Center there, and on the East Coast just in the healthcare system, you guys, state of Washington's light years ahead in terms of mindset as well as that feeling of being able to go forward in a positive way. Yeah. I would be surprised to see these numbers in many parts of the country.
On our next slide, I thought it was interesting when we asked everybody specific words that describe how they are feeling. The word that was chosen most was challenged. And on the second half there, empowered, only 6% feel empowered. I mentioned that this morning. I just think that's a really sort of, I don't know, I think it's just telling that the most powerful people in healthcare don't feel empowered. Peter, as head of Molina, the largest Medicaid plan in the state, there's a lot of changes coming to Medicaid, but you've been on almost every side of the healthcare spectrum. How empowered do you feel? Or, how do you explain this gap maybe? Because you guys are you're leading right into the storm, so to speak.
What they say about change is that it takes a burning platform, it takes a vision, and then it takes only one or two leaders who kind of seize the moment. I feel as if now is that time in Washington. I think we've got the perfect storm. The status quo that was clearly has become uncomfortable enough for enough people that I think there's a lot of optimism about the change. There's a roadmap. I feel very empowered right now to make change and to lead change. And I think my colleagues at Molina are feeling that way as well. Mm-hmm. It's clear that if we wait, this moment will pass.
Yeah. You know, I had a provider CEO come up to me today and ask, okay, this is all well and good. We talk a good talk, but how do we get to delivery reform? And Commissioner, you've been a provider, and Dorothy and Peter, you've both been on the provider side. Is there a responsibility for maybe the legislature to dictate, or maybe the exchange or the OIC to force or catalyze moving from volume to value more quickly? I know Medicaid is moving down that path. Commissioner, I mean, I guess I'd be curious about your thoughts about what we might do to force the delivery system to change maybe a little more rapidly than they would otherwise.
Well, I think that's really one of the big questions that we have right now. I mean, if we're going to succeed with healthcare reform, we've got to bend that cost curve down. If that cost curve starts to bound up, now we've got this for this year for the regulated market, the lowest rates we've seen in a decade, just over 2% increase. That's not something we're going to see reflected next year or the year after. If we're not successful in being able to improve quality and improve outcomes and hold the price down simultaneously. And that's one of the reasons why I was very favorable to the concept of having narrow networks, because I think there are opportunities there with narrow networks to both improve quality and outcomes and lower cost, and we're seeing that right now. At the same time, it's something we want to monitor very closely to make sure that it isn't abused, and I think that's the challenge. I was glad when we adopted that rule. I mean, there was just a crescendo of criticism over my movement to do that adoption, but I've never seen anything go from like the roar of a jet engine till somebody just shut it off. It went totally silent, almost just absolutely immediately, and no challenges. And I think what we've got is a lot more stability in our market right now than we've seen before. But we've got to have the regulatory procedures that allow for that kind of innovation to take place from the carriers, so that they're doing everything that is possible, with at the same time helping consumers have better choices too.
Yeah. Let's look at the next slide. And while we're pulling up, I just say we have a couple of microphones around. Anyone who has a question should just feel free to raise your hand. And I know everyone's tired at the end of the day, but if you want to ask any of these folks and not me a question, it would be great to have you raise your hand. So when we asked the healthcare community what they thought of how Governor Jay Inslee was doing on healthcare and health policy, 45% said they had a somewhat or very positive view, versus 29%. I think those are pretty good numbers. Dorothy, how would you measure the performance of health policy in this administration, since you're in it? I expect you to say it's fantastic, but through 2 years of an administration, that is a different kind of administration than the Gregoire and Locke administration. How would you answer the question of performance over the first 2 years? Give yourself a grade, so to speak.
Those are interesting numbers. I would say that one of the things that Governor Inslee did was to set a very broad but progressive framework for health care and health reform in the state, and then kind of turned those of us that he hired to work on this loose to do what needed to be done. I think he looked for folks and expected me and John Weisman, who's here today, and Kevin Quigley and DSHS in particular, along with our partners Mike and Richard in the HBE, to really work together, number one, and number two, to really seize the moment. As Peter said, we were right on the cusp of being able to enroll lots more people in health insurance, and I can tell you, we all know and knew, and I think the governor could see that that was step one, but it was only step one. So we were really, he wanted us to look beyond that to what we do once we did have more coverage for more folks. So I think the vision that he set that was reflected in part from the innovation plan that we built from the ground up with all of you really worked together. And his expectation is really that we collaborate and leverage the unbelievable talent and skill and innovation spirit that's in the state. And I think that's what you're seeing happening is the convergence going forward with a set of key principles and goals that we can all work on together.
So, Mike, Dorothy, you're both non-voting members of the Exchange Board and have both been, I think, vocal and at the board, and also, I think, active behind the scenes to the extent that I have sort of any inkling of any of the behind the scenes stuff in engagement with the Exchange. How do we hold the performance of the Exchange accountable for, some real stumbles? They've been, in many ways, top of class nationally, but still have real significant problems in terms of implementation. How do we drive accountability there without sort of sinking the ship in midstream, so to speak?
I think that it's too easy sometimes to just look at the problems, particularly when you're really, really close to them. And obviously, as insurance commissioner, in my office, we're very close to seeing what's happening and how it's working. But you need to kind of pull back and take a look at other states and their implementation. If you do so, we still rank very, very well. We do have some significant challenges, particularly around the information technology and how it works and where it doesn't work as well as it should. But I remain optimistic. I think the enrollment numbers are lower than what we'd like to see right now, but at the same time, they're ones that we saw it last time. There was just kind of a Oklahoma land rush at the end. I think that there's a lot of people out there that I think are still going to come through. So I still think we're going to meet the enrollment numbers, and that's really the major push that we have right now is to get that enrollment up. It's going to affect the revenues for the Exchange because of the offset against the insurance premium tax being the principal source for funding for the Exchange. After these first couple years where they had the federal dollars. So I'm reasonably optimistic, but I'm obviously also concerned we need to make these things correct because they have an unfortunate impact on consumers. And that's the part that if that reputation isn't something we can improve on, it comes back and it's seriously problematic. But so far, we're doing quite well.
I would add to just reflect pretty much what you said, Commissioner, and also say that we don't want to lose sight of the over 1 million people that actually moved through that exchange on the Apple Health side. So while this was a system that's been put in place to support both the public with the QHP market, but also the Apple Health or Medicaid market, and that has been a pretty phenomenal success. So I think the accountability question that you asked, it's a fairly accountable process right now where those of you that don't have board meetings in the public probably can't really feel how that is when every single thing that is done from a business perspective, every error, every mistake is pretty much out in the open. So it's kind of hard to calibrate, I think, sometimes when you've got all of these successes that are also out in the open, but then there's such a focus on the problems. And I would agree with Mike that the information system piece, which we can all relate to those being the death of us often in the past, is the biggest challenge here to get that right and learn how to work with an IT vendor in a way that we can see things coming in and respond to the issues there more rapidly.
So the 1 million people that moved through the exchange, I think I saw a release that said there may have 107,000 people worked through the exchange towards QHPs, or about 1/10 of the number of Medicaid beneficiaries. Mm-hmm. Should Medicaid cover 9/10 of the cost of the exchange then?
Well, actually, we should probably think through how that works right now. That we do, there's a very technically oriented calculation for how much Medicaid does pay for the exchange. So it's kind of arcane, actually, because it's all this cost allocation formula that you've got a big system. What is Medicaid using of that system and what isn't it? And you calculate from that the volume of the services. So we just recalibrated that. And I think we're close to 40% of the cost of that system now, which it's just about right, I think, relative to the investment that the federal government made in general to get the thing up and running.
Yeah.
So
I'm not going to ask you
I'm
to
happy
follow
to
up
give you
because
a
you've
lesson
just
in
been up here a
Medicaid
few
cost
minutes.
allocation.
Yeah. Let's see the next slide. So generally speaking, respondents to this survey leaned more positively towards the Democratic caucuses in the legislature. Perhaps that's no surprise if we think about healthcare executives being primarily based in the central Puget Sound region. System offices are often here. I sort of discount this a little bit because it's a big state, but the population is aggregated in central Puget Sound. I thought this was very interesting, however. This question we asked healthcare executives. We didn't ask consumers. We didn't ask people to which they were being marketed by providers or plans. We asked how favorably you viewed providers and health plans. And this is the top portion of scorers, so to speak. Mostly providers. Not a lot of plans. Kaiser's in there, Group Health is in there, Columbia United Providers, but mostly plans, or excuse me, mostly providers. Peter, you've been on the provider side, you've been on the plan side now and previously. What are your thoughts generally about this, particularly given all of the negative conversation that's been around price and consolidated health systems and narrow networks and some of that complexity?
So, you know, seeing this for the first time, this does not surprise me actually at all. Providers ultimately is where the personal relationships develop. That's for patients and for members of plans, but even for health plans, it's the relationship is providers. That's really where the rubber hits the road. So it's not surprising at all to me that there's a higher level of, or a predominance of providers at the top of that list.
Yeah. Questions from any of you? Just because you're tired doesn't mean you need to be shy. Yeah, right up here. JJ, you want to bring over a mic?
To Mike Kreidler, one of the frustrations that I've heard is people they live in County A, they work in County B, they get most of their health care in County B, yet they cannot buy a health insurance plan that covers the network in County B. Where they buy their health insurance plan is totally based on their home mailing address. What has to change to give consumers the ability to buy a health insurance plan across county lines, not to mention across state lines, but just across county lines?
Thank you. Sorry for having a cough here. That's something we continue to take a look at within the guidance that we have right now from the federal government. There are limitations as to what we can wind up doing as a state when it comes to those types of purchases. But we're going to, from one county to another county, depending on where you live. It's one that obviously we're willing to explore within the authority that we have to be able to go outside.
Other questions? You know, one of the nuances of the exchange as consumers experience, who, let's admit, particularly Medicaid and particularly low-income consumers are not always as health literate as they would like to be. But one of the nuances of the exchange dashboard as consumers experience it is that they cannot see co-insurance rates. And some of the plans that have been approved have as much as 50% co-insurance, which of course allows for a low premium, which is where consumers first go, is to premiums. Peter, should the exchange include co-insurance, or is that just too in the weeds? And And we're doing well enough with premium and in many cases deductible. And to be clear, co-insurance information is accessible on the exchange, but you have to dig into benefit design statements to get to it.
Yeah, that's a great question. I think all of us have a responsibility to demystify the process and the costs for consumers. In the perfect world, for me, I envision on the website for the exchange a calculator that compares each plan and translates for the consumer what the full out-of-pocket impact would be that would take into account co-pays, co-insurance, premiums, and maybe with some example cases, if you will. You know, if you're this age, or you can put in your own parameters, and then it would calculate the comparison. It's something that it's been frustrating for Molina, that very issue, because we've been worried that plans with very high co-insurance are misleading to many consumers the first time in. Yeah. Maybe not intentionally, but the absence of visibility kind of creates an incomplete picture when the purchase decision gets made.
Yeah. Let me ask you a personal question, just between you and me and no one else here. About this time last year, you were at a hospital system that I think some would argue is largely fee-for-service. And now you're at the largest managed care Medicaid plan in the state. Those are different circumstances in which to find yourself. How's it feel? How different is it to be on this side versus that?
Just between you and me?
No, I will keep it quiet. I definitely won't videotape it and put it on a website.
You know, I've had the honor of working with group health in the managed care space that lives really in both worlds, the provider space and the pure health plan space at this point, like Molina. And between you and me, there are not two sides. There are not three sides. This is all the same. It is kind of like the parable of the blind man and the elephant, of everybody's touching a piece of the elephant, if you will, and not having a picture of the whole. Yeah. I think one of our problems in this country, not just in this state, is we tend to think of healthcare in these silos of providers, or of sides of providers and health plans and maybe managed care organizations and others. And that's a problem. I don't think there is one. Yeah. I think we're all in a position to write history right now, every one of us in this room, yeah, at this moment of time and in this state.
Let's look at the next slide here. And this is not all of the questions, but these are some of them, and pardon us our errors on the document that you have on your flash drive. But based on what you know about the state innovation plan, generally speaking, how optimistic would you say you are about the future of the plan? And those are relatively good numbers. Not a lot of commitment on the very optimistic or very pessimistic side, but pretty strong response is somewhat optimistic. Again, Dorothy, those are pretty good numbers, I think, for you at the Healthcare Authority. I want to ask you sort of two questions. First, what is your vision for the performance of accountable communities of health, a key component of the plan? What should those be, and what should those be doing to the healthcare system in 3, 4, 5 years?
So, you know, if you all know the Christensen theory of innovation, if you think about, for example, mainframe computers that are now on our smart watches, Google Glass that I saw today, moving out, everything's moving out. The more innovative, the smaller, the more focused on, outside institutions and out into the community, I guess. I think of ACH as in that way, that they're the next level of innovation that we can actually now implement, operationalize to support our healthcare systems, to support our plans, as Peter said, to support our populations, really, to help What we know is, we all know this is true, that health of a population relates obviously to extremely high quality, cost-effective, convenient, accessible care, but in addition, it relates to making sure that those where you live in your community is a healthy community that has access to parks and community-based support services if you're trying to manage your diabetes, those kinds of things. So I think I see the power of the ACH as being that extension of a healthier Washington, which is what we're all aiming towards, and the ability to then have everyone sit around the same table and say, we've got a problem with an obesity rate of our third graders in X region, or we really want to focus on smoking cessation, or we don't have enough orthopedists in our area, or whatever it is that seems to be a health issue, that everyone is sitting around that same table solving the problem, not only with their own resources, but with their knowledge, with their connections, et cetera. So I actually don't believe we'll be able to achieve that triple aim without accountable communities of health. We can get somewhere there. We can obviously get at the reducing cost of care to some level. We can obviously get at improving quality, but that health piece of it, I think, and overall health outcomes is going to be tough to get to. And I think of those as much managing your blood pressure or your diabetes as I do health outcomes in terms of morbidity and mortality rates over time. So I just believe that those are this new structure. I was talking to Larry Thompson, I don't know if he's here today, saying, just since there he is, just since we've had these in place, there have been, for me, so many ways that I've been able to say, why don't you contact this organization that's the ACH in that region? They probably will be able to help you solve that problem. So it's a new piece of infrastructure that's collaborative. It's a problem-solving infrastructure. It's bringing the system around the table that I think will really help us truly and in a more rapid way achieve that three-part aim.
Other questions from you all?
DJ, I might just add, I think it really fits with what Peter Adler was saying and Dorothy has just said, and I think it's that these first couple years now with healthcare reform are kind of the Wild West. There, a lot of things are going to be tested. It's almost what's going to wind up surviving and what's going to really provide value. And I think we're all trying to figure out how we can help to stimulate that kind of innovation. At the same time, we want to make sure that consumers aren't disadvantaged going forward. And that's a real challenge right now, that you can wind up with some market disruptions that are a major step backwards if you're not really careful. At the same time, you don't want to stymie that innovation. You want to encourage it, but within certain game rules, and that's a challenge.
So let me give sort of a real-world example on that, I think, and maybe Dorothy, I'll ask you, and then I'll ask you, Mike, to follow up. In Washington State, generally, we have a premium to reserve ratio for health plans, MCOs, of about 8-to-1, I believe, and though there's some, I think, wiggle room within the commissioner's authority to manage that. In a state like Oregon, where they decided to integrate ahead of us mental health funding with physical health funding, while they have commercial MCOs have a 10-to-1 ratio in Oregon, the Medicaid plans that integrated mental health and physical health moved to a 20-to-1 premium to reserve ratio. And for those of you that aren't math majors, if you have $100 million in premium, if you have an 8-to-1 ratio, that would mean you have to have $12.5 million in your reserves in Washington State. In Oregon, and for Medicaid, they went so far as to go to 20-to-1, meaning if you have $100 million in premium, you have to have $5 million in reserves. And so the consequence of that is more dollars are taken from reserves to allow for innovation and taken from reserves which open up risks potentially to providers or consumers. Dorothy, first to you, to get through this period of transformation, this wild, wild west, where we're integrating mental health and physical health, should the commissioner relax premium to reserve ratios for health plans that are integrating mental health and physical health?
I don't have the answer to that.
Dorothy, I'm going to let Dorothy answer first, so then you can tell her she's wrong.
I don't have the answer. Oh, yes. Whatever I say, you can say it's wrong.
No.
I don't actually have an answer to that. I would only say that the integration of physical health with behavioral health at the end of the day is going to drop our total costs of care for our populations. And to get there, it's very risky not to do that, whether you're looking at it from a health perspective or an insurance actuarial perspective. So to the extent that we go forward with that integration, which will help on health, it'll help on care costs, it'll help on overall quality of life for folks. We're gonna have to keep our eye on the ball in terms of that long-term overall benefit that's going to be there, both financially in huge ways, but also from a health perspective. I don't know, Mike, what...
I think, in the end, we're as a regulator and it's consumers, all of us, so we're very concerned to make sure that the solvency of these enterprises are not compromised. And I think it's, to the extent we can come down, and we're not going to wind up. When I came into office, obviously, there was one major health insurer that was already being liquidated at that point, or it was already in receivership, I should say. We avoided liquidation by having another insurer acquire them. But that kind of disruption is very harmful, and obviously that could compromise whether you have a commercial carrier or a Medicaid carrier or whatever. It might not be here tomorrow if you're too lax in those rules. But I think I think it's one of those things where we have an opportunity right now. We're learning a lot going forward, and I think we're going to be able to make adjustments where it's appropriate, but at the same time, we don't want consumers to find out that the insurer that they have isn't going to be there tomorrow.
Yeah. Peter, how about, let me frame the same question to you in this way. Molina, I believe, I think they're in 13 states. Is that accurate?
11 states.
11 states. But more than half of the lives at risk are in Washington State? Is it half of the risk membership is in Washington State?
Washington State is the largest Molina plan.
Yeah.
With 500,000 lives.
Do you think, so you have the capacity, if any Medicaid plan, and the experience and the human capital to weather this storm. Do you think that this is a topic the regulators should take up, that maybe a little flexibility on some of the regulation, including premium to reserve, during this time of transformation is warranted?
So I agree with Mike's comments on this, that I do not think innovation should be a reason to relax the reserve requirements for health plans, because we're talking about innovation that's taking us into population-based risk, which is not a place that ACOs or providers have been or have the reserves to safely go, whereas the health plans have built those reserves, they have those reserves. I think a better way to go with this is to separate those, recognize that a period of innovation will need additional dollars. But the source of those additional dollars should not come from relaxed reserve requirements. Innovation grant, the kind of creative work that the Healthcare Authority and the state has done to bring in additional seed money at a time that we need it for change, is, I believe, the right funding mechanism, if you will, an external source for innovation. That should only last 3 or 5 years, though, and then we need to be at the new reset point. But through that period, I do not think we should relax reserve requirements.
Questions from you all? I could just call on you. If I'm staring at you, it means you might be called on. As we wind down, I'll ask all of you, and Peter, I'll give you the first word, and we'll work across the stage and give you, Commissioner, the last word. What advice would you give to either the legislature or to the governor and for you, I'll ask you to give advice to the healthcare system. What advice would you give to the legislature or the governor, in this time of fiscal distress, where we are at the same time taking on transformation? What should they be keeping in mind as they work through the legislative session?
Primary care, integration, and speed. So I'll put a few more words on that. Primary care, it hasn't come up all that often today, which has surprised me, but the entire basis of population health and medical-based home, a medical home and care coordination requires primary care. We don't compensate our primary care providers or community nationally, not just in this state, but in this state, adequately to take on that additional responsibility, which is just core to the innovation and the vision and the triple aim. In ACA, there was funding for 2 years that, as we all know, supplemental funding for primary care that dropped off expired as of December 31st. It is in the governor's budget proposal coming to the legislature, but we should be all over that to make sure that that happens and it doesn't get touched. So primary care, because all of this innovation and the innovation grant and triple aim, from Molina's perspective, will not happen. It will fail if we don't have a strong and vibrant primary care community that is growing. Second is advice is the integration agenda that is on the table. And I will argue with you to the legislature that we need to go further than it on the agenda. Today we have this very fragmented environment, as we all know, and we talk about behavioral health and physical health, but we've left dental out, we've left long-term care out. We should truly, if we're going to achieve a healthier Washington as is envisioned in the innovation grant, that all needs to come together in integration. And the health plans need to be given the opportunity to care for populations around the whole person. So that'd be the second one. And then the third is speed. I think regardless of one's political persuasion and regardless of how we got to this moment in time, we are at an unfrozen moment right now in this state because we are an expansion state, because we do have an exchange that is functioning better than most other exchanges in the country. It has its issues. And we just, thanks to the good work of Dorothy and her team and many others, we have millions of dollars of innovation grant money coming in. We've got a window. I think it's to your question about empowerment. I think this is one of those carpe diem moments. So to the legislature, fund primary care well, integration for the whole body without anything left out, no body parts left behind, and speed, move now.
Should they raise taxes to be able to get there? If that's what it takes, if that's the difference, should they raise taxes to be able to do it according to Governor
There's a
Inslee?
politically neutral question. I'm of the belief, and I may be a voice of one, I'm not speaking for Molina now when I say this, I think in the healthcare space in aggregate, in all of the silos, there is enough money. If you take the money flowing into Children's Administration and DSHS and the HCA and the prisons and through CMS, through Medicare, if we would look truly at whole communities and the aggregate, all the dollars coming in, I think with the innovation grant money as the stimuli, I think if we change how we do what we're doing, that no, we do not need to raise taxes for health care.
Yeah, good. So Dorothy, either to the marketplace or to the legislature, what would your advice be?
Let's see, marketplace. I think that, and this is, you all know me enough to know by now that I'm quite an optimist, because I look for the positive energy that's in the market when I'm saying this. So I think it's to not let up with the amount of innovation, the amount of, I call it clinical intelligence that I see coming to the fore in terms of the clinicians, the delivery systems that each and every day see the patients that we need to take care of, that they come together and really understand the concept of total cost of care, and learn from the country about, there are some other places that are, as far along as we are, maybe a little further, about how you can actually move fairly rapidly if we put our collective minds to it and don't let up and don't worry that somebody's, if we focus on the patients and the people that we're responsible for, while it's a competitive market, I think there's still that opportunity as we go forward to move away from paying for widgets into a concepts of total cost of care, working with our communities. And if I were in a delivery system and an exec there, I would be saying, get our clinical teams together and tell us what to do, how to do it, get our community partners in the room, spend some time doing that up front, get everyone together is gonna, that design work and that moving forward is going to really help in terms of the speed that Peter was talking about. And I do feel like this is that time that we've got to do it. In terms of the legislature, I have to really appreciate what the legislature did last year for healthcare policy. From my perspective, with the exception of the transparency issue that I have very much confidence will get resolved this session, we have what we need for all of you and for us to do from the policy framework perspective to move forward with what we need. And while I would absolutely agree with Peter, I don't think we need more money. We certainly cannot reduce the dollars that are in the healthcare budgets. We've got enough to move forward, I think, with all the different pieces and parts that are out there, but we cannot reduce the healthcare budget, so it'll stall us out, because I think right now is our time to be moving ahead.
Great. Commissioner?
Well, certainly one of the funding issues that I'm very concerned about is the funding for the health insurance exchange and making sure that that's adequately funded. And much of the rest of what we're looking at right now is largely coming from Washington, D.C., and from the federal government, from Health and Human Services, Department of Labor, and other federal agencies that have interaction with us. And so I'm probably more focused there right now than I am here at the state level. I don't anticipate a lot to happen. I want to make sure that the money that is there isn't compromised in some fashion, or that they underfund the exchange. That would obviously be seriously problematic in being able to go forward successfully. But we're not far away from talking about innovation and change. The federal government's in the process right now of going to move up the open enrollment period to October 1st. So for the last 3 months of this year. So 45 days earlier, and that puts a lot of pressure on people like me that have to get those plans filed with us and make sure that we get them approved before October 1st. And we need to make sure that we not only approve just the plans inside the exchange, the qualified health plans, there's a larger market outside of the exchange that we regulate, and they have to still meet the same standards as inside the exchange and relative to the essential health benefits and all of the other requirements that they have. So we want to be able to approve, have all of the filings come in at one time, inside and outside the market. We're going to be pushed to, because we had those filings come in on the 1st of May. 45 days is not very far away if we move it up, but we're looking at right now moving it to April 3rd for those plans, and that's less than 3 months from today. Mm-hmm. So it's not very far away when we're going to get those plans in, and this time we need to be able to, and the federal government's moving that way, to have both the inside and outside market approved at the same time. So this is going to be a huge regulatory challenge. So I'm probably more focused on that right now, just because we're with everything else that we're doing. We got all of these plans, making sure we get them through, give them the kind of thoughtful attention, look at some of the innovations that are being proposed to make sure there aren't adverse impacts on consumers. So that is really what is taking our full effort at this point.
I think that's such a big deal. That issue you talked about there, people, maybe the end of the day, and people may have missed it, but I think that issue is a huge deal for the 2016 insurance marketplace and 2016 delivery system. Let's give them a round of applause. Thank you very much, everyone.